A very good morning to everyone. Thanks for watching the NIH Continuous Medical Education CME 2025. My name is William. I'm the current head for Digital Health Research and Innovation Unit under the Institute of Health, Malaysia. Today, we are very honored to have Dr. Muhammad Aizuddin Abdul Rahman with us to share about his experience in leading and conducting a clinical study using virtual reality VR to treat anxiety disorder. Dr. Aizuddin is the former head of a Digital Health Research and Innovation Unit established in 2020 under the Institute of Clinical Research, ICR, Institute of Health, Malaysia. He obtained his degree in Biomedical from Management and Science University and worked in the medical lab industry in 2007. He then pursued a medical degree and graduated with MBBS from University of Cyberjaya in 2011. Since then, he served the Ministry of Health and now in his 14 years of services. Before joining ICR, Dr. Aizu worked in the clinical field and spent a significant amount of time with the surgical fraternity. However, his enthusiasm for research has taken over, and he was then tasked to lead a group of clinical researchers in Clinical Research Center, Hospital Sungai Buloh from 2016 to 2020. The establishment of DHI under his leadership was timely, as the unit was created during the boom of digital transformation, especially in the healthcare sector. The DHI team aims to incorporate digital health technology in healthcare through ethical and quality research, and has been doing that since 2020 with various projects under his leadership until he stepped down to further his study in August 2023. Dr. Aizu's research interests vary from entomology, non-communicable disease, communicable disease, pathology, surgical to health innovations. He is currently pursuing a master's degree on medical artificial intelligence and image processing under Swinburne University of Technology, Sarawak. Before we start the CME, ladies and gentlemen, let us enjoy a video montage about Institute for Clinical Research, ICR.
Established in 1998 and formerly known as Clinical Research Center, the Institute of Clinical Research, or ICR, is one of 6 research institutes under the National Institute of Health, Ministry of Health, Malaysia. From humble beginnings, the institute witnessed growth and expansion over the years and now comprises of 5 centers and a network of 36 branches in major hospitals across the nation, including periphery in Sabah and Sarawak. Strategically located within the National Institute of Health's headquarters in Setia Alam, ICR comprises a welcoming, modern, multifaceted structure with shared state-of-the-art facilities. With a deeply rooted mission to improve patients' health outcomes through ethical and quality clinical research, ICR positions itself as an institute that provides patients access to leading research in medical and surgical fields.
As a national institute, ICR's primary core role is driven by critical strategic, interrelated functions such as providing leadership in development of clinical research capacity.
Establishing and maintaining clinical database has additionally been an imperative and ongoing functions for the institute as they continue to deliver for the Ministry of Health.
Attributes of CRC Hospital is that there are different specialties of research within each of CRC. For example, CRC Sarawak is renowned for its cardiology research, CRC Ampang for its hematology research, and CRC Sultanah Bahiyah for their hepatology related research.
As part of their objective to provide ethical and quality research, ICR takes pride in coordinating the conduct of industry-sponsored research, while additionally promoting the conduct of investigator-initiated research.
The Institute continuously establishes collaboration with local, regional and international research organizations in the pursuit of excellence in clinical research for the country. Through these collaborations, the Institute for Clinical Research is also able to facilitate the establishment of hospital clinical research centers These interrelated core functions go on to fundamentally converge into one overarching principle, that is to provide research that matters for patients.
The Institute of Clinical Research essentially operates under different areas of expertise: clinical trials, bioavailability and bioequivalence study (BABE), clinical epidemiology, national healthcare surveys, digital health research and innovation. More importantly, the scope of research is not only confined to these specific areas. The Institute acts as a platform that provides an entire ecosystem of clinical research for medical professionals and academia in Malaysia, both public and private. Together with its unique attribute of being a civil, service-driven institute, ICR is poised to become a leading clinical research institution in Asia. As ICR continues to lead nationally, the institute is also no stranger to making its mark in the global healthcare and medical industry. Through its clinical research and trials, Malaysia has become the first country in the world to provide affordable tablet treatment for hepatitis C. This is a step in the right direction as the Institute further solidifies its commitment in translating medical innovation into the very essence of its motto, providing research that matters for patients. Built upon a strong foundation and strategic functions to providing leading research in medical and surgical fields, the path is set for ICR to continue creating global impact and become a leading clinical research institution in the face of Asia.
Thank you for watching the montage. Dear audience, if you have any questions during the CME, please use the link in the description to pose your questions. We will provide response accordingly. At the same time, please verify your attendance using the link in the description in the YouTube page as well. You will receive a certificate of attendance after a week. Without further ado, let's start the presentation entitled Virtual Reality VR in Anxiety Treatment, Effectiveness and Obstacles. Perspective from a randomized control study by Dr. Aizuddin. Please.
Okay. Assalamualaikum and good morning. Thank you, William, for the kind introduction. I think it's not too late to say Selamat Hari Raya to all. So I'm here representing my team, a group of researcher in DHRI and my fellow clinician, especially in psychiatric for this case, to share our experience and some perspective. So let's give a context to this GAD first. We know that the case of mental health has been increasing over the past few decades, and COVID-19 has shown us that the prevalence are even higher than reported. There are gaps in our healthcare and they need to be addressed, and patient-practitioner ratio is one of them. Another one is to get our younger population to come and seek help. We seek for new tools to help us in battles against mental health disorder. Now, by no means this is a silver bullet, but we believe that this is a good adjunct tool as this day. We then designed this study with inputs from clinicians on the ground, and we decided to tackle on GAD. Now, GAD is a very specific issue when we're talking about anxiety disorder. So it impacts quality of life, and we can see that it impacts functioning. Unfortunately, GAD affects more of, you can say, productive population, younger age, that contribute to GDPs in our country. So we can see the social impact and economic impact is huge. There are standards of treatment such as psychotherapy, cognitive behavioral therapy and so on, and then pharmacotherapy. So we believe that virtual reality is an emerging adjunct with immersive therapeutic potential. Now, the study rationally our study was built on rationale that VR is accessible, scalable, and complements standard therapy. Because we know GAD prevalence and treatment limitation, we believe that VR as non-invasive and scalable intervention can help in terms of this. However, clinical trial in this area, especially psychiatry, is very, I can say, very rare or small in this region. However, there are various studies outside our region that look into VR in various applications. In fact, FDA, Food Drug and Administrator, USA, have recently approved VR for pain management. We understand that mixed reality, whether it's VR or AR or other technology that related to this, still is in infancy in the country in the context of healthcare. So we seek to explore this technology as adjunct to standard of care. This is the objective of the VR GAD trial. We not only testing on the effectiveness and acceptability, we also look into operational feasibility, and which is critical for real-world implementation. And in this trial, we also explore on patient and our clinician experience using VR firsthand in treatment. Now, some trial overview. This is a multi-site parallel RCT, randomized control trial, comparing standard of care to standard of care plus VR. The recruitment span for 8 months. We have 5 sites: Hospital Kulim, Hospital Sultanah Baya, Sultanah Zahira, Permai, and Sultanah Aminah. So basically, we are doing in Kedah, Terengganu, and Johor. This is our timeline, study flow and timeline. A clear roadmap is very important to help coordinate effort across sites. We have received relevant approval prior to conduct of this study. Now, this is some eligible criteria. This is non-exhaustive list. We will later on publish our study, so I only share some of the criteria. This criteria is established strict eligibility criteria to minimize confounders, and all participants were free from major psychiatric comorbidities and able to use VR safely. Now, when we do the sample size calculation, thanks to our statistician, we come up with the numbers of 76. Then we decide as a team that to include dropout rates. So we aim for 80 participants based on the prior data, and aim for site balance using block randomization. So the randomization process triggered by study site, and process was conducted by independent team in NIH. Now, this is an outcome. We wanted the primary outcome is GAD score at baseline, 2nd, 4th, and 8 weeks of treatment. So for the secondary outcome, we are looking at acceptability, satisfaction, and well-being using all validated tools. So okay. For VR intervention, I will just summarize this. VR module use are registered with FDA, and actually is used commercially in Europe to treat clients. But in this trial, we simply wish to demonstrate the technology used in Malaysia within the scope. It's 5 immersion VR module over 4 weeks, over 8 weeks, 15 to 20 minutes session at site. The module consists of either grounding, breathing, relaxation, nature, and mindfulness. This module used as adjunct as therapy goes along with the standard of care. But the clinician hold the final decision to use which module they deem suitable for their patients. So this is the first clinical trial we conduct as a unit in the HRI, even though most of us have experience either conducting or facilitating industry-sponsored research. So using that experience, we develop set of SOPs, standard operating procedure for clinical trials. And this standard operating procedure is co-developed together with our team at the ground, so that it makes more sense. And we are using this trial as first trial to see whether we can improve more on the protocol SOP. This measure helps us to efficiently conduct trial in multiple sites simultaneously. All sites were equipped and trained according to the SOPs. We delegate roles using standardized forms and monitored consistency through multiple checklists and virtual meetings and site monitoring visits. Now, for the recruitment strategy, we rely heavily on the site referrals and flyers to recruit. The screening done by the PI and research assistant to ensure clinical appropriateness. And consent and baseline in-person evaluation has done before the patient enroll in the trial. The SOP framework. So each site was provided with investigator file consists of relevant approval, study protocol, and multiple checklists and forms to conduct the studies. So again, SOP is the key. Each action from from consent to VR setup and use was guided by the standard document ensuring fidelity of the trial. We have, I think, total of 13 SOP created to standardize implementation. So during training, we are using these SOPs to standardize our training to each site. These are sample of the SOPs. You can actually obtain these SOPs by contacting us if you're interested to use it. Now, for training and delegation. So all staff that involved in this study are required to join the physical training. So what we did was first site initiation visit, we will have a physical training, and then additional staff or new staff coming in, or we will do refresher course via virtual. And we documented all this in the training log. We also have supervised role play for VR setup and then some troubleshootings hands-on. These are done to ensure the staff proficiency. So participation tracking required with several logs. This to ensure transparency, safety, and traceability throughout the study. Data collection, we are using standardized data collection. This is a secure research-based data collection tools called RedCap. It's hosted in NIH, Setia Alam, and then standardized digital question, secured, timestamped, and monitored for completeness. Each access to RedCap will have their own logins to the systems. Real-time monitoring done by our team from Setia Alam to ensure that there's less missing data and the protocol drift or protocol violation. So monitoring and visit summary. We did a site initiation on February 2023 and then monitoring throughout the years. And then we also did a close-up visit to ensure that all the documents on the trial are conducted accordingly. Now, on top of this, we also have a weekly meeting with the research assistant to ensure that all the trials are conducted according to the SOPs, and if there's any issues, we can tackle immediately. Now, the plan includes specific criteria and checklists, their consent review, SOP adherence, and AE logs. So for those who first time learning about clinical trial, in clinical trial, we do strict monitoring of patient safety. The most important part in clinical trial is patient safety. So we have adverse event reporting, even as simple as patient complain they are not comfortable, even with sitting without using the VR, is something that we also log in and report. We also have verbal and written feedback after each visit from both patient and staff. We also have our own dashboard, this one created by using RedCap. So there are some minor deviation. There are some non-serious delays. So we have 7 AEs or what we call adverse events. So patient complain of dizziness, headache, and nausea. But these are resolved immediately during the procedure or resolved without sequelae. Now, and we also document this. For trial withdrawal, we have 4 total withdrawal in this study. We've seen that most of the reason of withdrawal are because of personal logistic issues and schedules with their daily life. No safety related protocol dropout we've seen. Withdrawal reason is very important for clinical trial because we wanted to see whether later on we will have problem when we scale this treatment. Now, For data management, we have local site RAs to do data entry and follow-up. And centrally, the HRIC team will do backup and audit trial. We have each PI or primary investigator at site to approve each protocol before the final report is signed. To ensure data security and confidentiality, there are a few things that we did to make sure that these are within the law. One is we get a proper approval before we conduct trial. Second one, data sovereignty is under Ministry of Health, and participant IDs. All participants are assigned with unique ID to ensure that their identity is kept protected. The only one who knows patient identity is the clinician that treat them. Okay. So end of study, data handling. So final database locked in November. And all the files are stored at site. Reports are prepared by the PI at site and then with DHR support. So finally, because this trial is still under publication process, we will not be able to share most of the results, but we met the target in conclusion. And maintain high completion rate. I think more than 90% of all the patients completed their session each time. So this is a proof of good engagement and then site commitment as well. We have balanced site contribution. These are some demographic. Majority are female. We have predominantly Malay population. And then these come from diverse employment and education status. I think the age is between 30 to 50. JD completion rate, as I mentioned earlier, more than 90% completion at each time. Means that every time they come for the VR session, they will complete the session. They here means patients. Every session, the time we're suggesting between 15 to 20 minutes on top of their normal routine standard of care. In average, we seen 15 minutes. And we have good acceptability score for 4.2 over 5. Now, what are the operational lessons learned during this one? One is VR integration, I think, feasible with clear SOPs. And we can smoothly integrate into routine care with proper SOP and contingency planning. Early training and engagement are very critical for supporting staff and for patient, I think more to health education. And there are some logistics. Backup for the VR unit is also essential because we don't want to have interruption in service later on. Scheduling flexibility improve retention, but I think scheduling flexibility comes inherently with the psychiatry service. They have more scheduling flexibility. So for recommendation, we recommend co-developing the SOP with site, piloting VR in real setting, allowing participation flexibility, especially in terms of the appointments. So we have some other recommendation. One is a budget for tech maintenance and user support. Consider participant digital literacy in recruitment, and pilot test all VR content pre-deployment. So I would like to take this opportunity to thank all site PI. We have site PI Dr. Nadia, we have Dr. Marina, Dr. Chong, Dr. Swaila, and Dr. Amit. I can't see them. And then my team, DHRI, there's only 4 of us, but we have more than 4 to help us throughout the study period. So these are some trainers for VR system. You can see this is our industrial partner, COSET. They actually come and train us multiple times to ensure that we knows how to use a VR system and some troubleshootings. And then we do site initiation visit. This is where we train all the site personnel to use the VR and also familiar with the study protocol. We do have this. This is from Sultana Amina. I think half of the department joined during this session, and everybody is interested with this technology. From all this site visit, we know that most of the staff are familiar with technology. I think our generation are born with digital technology naive compared to our previous generation. So hopefully this technology can be used to improve patient care. So this is a monitoring visit. So what we did during monitoring visit is to ensure that all documents are up to date. If there's any issues with the conduct of trials and some supports if they need. And then we did a technology transfer where we explore on the VR technology. Or I think during this time we actually goes beyond VR. It's more to extended reality. We also have augmented reality. So we have a writing workshop with the team. This is in order to publish the result of the study. Thank you. Again, special thanks to the HRI team, study team led by each site PI, MRG committee or MOH Research Grant Committee that provide the loan, the grant for the studies, and then industrial partner COSET to that stay with us until the end of the study, providing technologies and research assistance. Thank you. So I think there are some questions I would like to throw to the audience. If they can keep this question in mind. What would you do differently in your own clinical trial if you happen to conduct one? What would this model work in other psychiatric condition? Yeah, thank you.
Okay. Thank you, Dr. Aizuddin, for your wonderful presentations. When I look at your presentations, I realize that there are a number of preparations that need to be in place to get a multi-center study conducted according to the milestone and timelines. Well done for your, for the study, and well done for the team together with all the clinicians. We do receive a few questions about your presentations. One of the questions is, please provide more information on the tool used to measure the effect of VR in anxiety as part of anxiety treatment. Would you mind to provide us with more information on the tool used to measure effects such as effectiveness, acceptability, and also well-being of patients? Thank you.
Okay. So when deciding using the tools, we actually explore multiple tools, especially on the anxiety scale. But then we quickly realized if we want to scale this, it need to be something that people are already familiar, because using VR is not their routine. So adding more non-routine things gonna be a bit challenging. So what we did, we finally settled down on G87 as a measuring tool for general anxiety, and then for adaptability, we are using adaptability score for technology. For well-being, of course, we are using WHO well-being 5 questionnaire, I think. Yeah, 1 second. So all these are validated tools. Yeah.
Okay. So from our presentations, we get to know that for effectiveness, we use a GAD-7. It's a 7 items validated questionnaire. For well-being, we use a WHO-5. It's a 5 items well-being questionnaire. For acceptability, we have a validated acceptability for new technologies.
Yeah.
Okay, that's good. That's good. Okay. Beside this, during the study periods, right, is there any positive feedback or even negative feedback received from the patients or even the site investigator for using VR in anxiety treatments? Would you mind to share with us about this?
Yeah. Okay. So let's start with the staff first. The investigators, of course, obviously, some of them are familiar with the technology. So the first thing is that they're very excited. The common feedback I think we receive throughout the studies is the ease of use, and then it may even the retention for the staff using the device. Of course, the challenge will be on the infrastructure side. Those are the things that I think we need to improve along the way. But for patient, initially we thought that younger generation will be more positive towards using VR, and the older generation are not that much. But in this trial, we see that is not the case. Most of the patient that luckily we have higher retention.
Okay.
Most of the patient also interested to use VR, and then we have even the older generations are interested to explore more than what the module that we offer have. Actually, in the system they have more module. We only choose 5 for our studies. So that's when the patient have they wanted to explore more. It's a good thing. I think the other feedback is sometimes there's a lag again because of the infrastructure. Yeah.
Okay. Yeah. Okay. So good. Before these presentations, my impressions about VR is in gaming. Now we start to see, the applications of VR in even in treatments. Okay. So besides anxiety, would you like to comment on the future prospect of using VR, probably for other diseases or other disease domains? What is the future prospect of using VR in healthcare services?
I think the barrier to use VR now is reduced. VR set now is relatively affordable. Some even goes less than 1,000. So that's one. And then two, we've seen a lot of positive impact from patients using VR as either adjunct to. Of course, in European or US, they already use for some pain management and all.
Okay, pain management.
Of course, we've seen a lot of specific phobias also being used for using VR for these treatments. I think it's not only cost effective, it's also scalable. Hopefully, we can promote more the use of the technology to our patient. But I think with proper guide from healthcare, we can now make these tools more effective for our population. Of course, VR may not be suitable for everybody, but we do have a population which much more affected with the GAD can also benefit from VR.
Okay, good. So in the whole study, I see that NIH or DHRI plays a significant role in driving the study toward the end. So would you mind to just highlight services provided by NIH or DHRI to ensure the success of study? What are those services?
So I think we as a researcher, we have a role to help our fellow clinicians to tackle a problem that they have on the ground. These are real problems that they have facing day to day. From research point of view, sometimes we need to go down and understand, even though some of us are clinicians previously, so we wanted to know what happens in the ground or real time. So these are important for DHRI to come. I think the rest of NIH also been doing this. What we did was we go to the ground, discuss with clinicians and provide service in terms of, one is to see what are the clinical research questions that they have that maybe we can help design the studies on that.
Okay.
Other services that we may also provide is if they have their own study and they don't have enough team, we can be part of the team.
Okay.
I think in the studies we also help them in terms of providing statistical service,
Okay.
randomization.
Yeah, that's
and
great.
I think the SOPs later on can be used, replicated for other clinical trials if they wanted to. And from this experience, we know that it's easily deployable. With just one click, everybody can get the and they can easily understand that. So yeah.
Yeah. So it's more like a collaborative efforts. I can see how a researcher and clinicians work together to deliver something wonderful and impactful for the populations.
Yep.
Okay. So let's see if there are any questions on this topic. Okay. Yeah. Okay. I think there are no further questions. Okay. So again, I would like to thank Dr. Aizuddin for your presentations. and also your sharing on collaborative research, multi-site, randomized control study to really evaluate, the impact or effectiveness of VR as an adjunct therapy for anxiety disorder. Okay, this I was told that this was the first trial on
for the unit, yes.
Yes, for the unit on using VR as a part of the treatment to improve anxiety symptoms. Okay. With this, I would like to thank Dr. Aizuddin again, and also the audience for spending time watching this CME under the NIH Malaysia. Thank you, everyone. Have a nice day.